Welcome, everyone, and thank you for joining us as we hear about initial learnings and insights from Gavi's learning agenda on malaria vaccines. We are very pleased to have with us Dr. Eleonora Genovese, a senior program manager of the vaccine programs at Gavi, Dr. Alici from the Centre de Recherche en Santé de Nouna, Burkina Faso, and Dr. Daan Velthausz, director of Maraxis BV in Mozambique. By the end of last year, 25 countries had introduced malaria vaccines, and this is the first of a year-long series to share challenges, learnings, and innovations that have been part of that rollout. Stay tuned for our next webinar in April in advance of World Malaria Day. This event will have simultaneous interpretation to French and Portuguese. To hear it in your language, click the interpretation or global icon at the bottom of your screen and select your language. Please use the Q&A icon at the bottom of the screen to pose your question to the panelists. With that, I am pleased to introduce Dr. Eleonora Genovese to provide an overview of Gavi's learning agenda. Over to you.
Thank you very much, Saira, and thank you to everybody who is connecting today and all the work that has been made so far for the malaria vaccine learning agenda. It's a big pleasure for me to represent Gavi Alliance, and I would like to start with a brief overview of the malaria vaccine learning agenda. First of all, reminding everybody, of course, the importance of these malaria vaccines, because malaria remains a primary cause of childhood morbidity and mortality worldwide, but especially in the Africa region. And WHO recommends the programmatic use of malaria vaccines for the prevention of Plasmodium falciparum malaria in children living in malaria endemic areas, prioritizing areas of moderate and high transmission. And very importantly, the malaria vaccines should be considered part of a complementary toolbox, providing a comprehensive malaria control strategy approach. Now, to support this innovative toolbox to fight malaria, Gavi board approved support for the malaria vaccine program in eligible countries in 2021. In December 2021, Gavi board approved support for the introduction, the scale-up, and implementation of malaria vaccines in areas of moderate and high transmission areas, indeed, as part of a comprehensive strategy. And the first window of applications open to countries was in March 2023, where countries were given the opportunity to apply for receiving this support. And since then, Gavi has been maintaining multiple application rounds every year. And up to now, in total, 26 countries have approved applications for introduction support, and 15 countries have approved applications for scale-up support. And the rollout status as of today, basically, in total, 25 countries have so far introduced malaria vaccines, and 10 of them have scaled up in areas, of course, of moderate and high transmission. And this is virtually corresponding to the distribution of malaria transmission in the Africa region. So because of some open questions regarding the programmatic use of the malaria vaccines, Gavi has also provided support to conduct a learning agenda. Basically, a number of research questions have been identified, and a learning agenda has been conceptualized to provide evidence and information and knowledge to answer those questions, to therefore optimize the use of malaria vaccines. So the learning agenda is structured around two main aims. Aim 1 is about uptake and basically revolves around identification of approaches and interventions to increase the uptake of malaria vaccines along other key health interventions, key primary healthcare interventions. First and foremost, other antigens, but also other malaria prevention and control strategies and other child primary healthcare interventions. So this is a very synergistic approach to increase uptake of malaria vaccines while also increasing uptake of other key interventions to reduce childhood morbidity and mortality. Research aim number 2 revolves around seasonality. So it's specifically focusing on areas of highly seasonal malaria transmission. And it's about the comparison, the comparative assessment on the feasibility and effectiveness of alternative schedules and delivery strategies of malaria vaccines in areas of highly seasonal transmission areas. So it looks at clinical effectiveness and also cost effectiveness comparison. In the next slides, we have more information about the specific research questions, which basically revolve around the identification of scalable interventions, the identifications of strategies to particularly identify due defaulters, late and missed children for all EPI, malaria, and other primary healthcare interventions in a synergistic modality, looking at dimensions around acceptability, cost, feasibility, and impact. So it's very action-oriented, and the research questions for aim number 2 are very much around the operational, financial, and social feasibility of alternative schedules. So as you know, right now we have age-based strategy in most of the countries, and they are implementing the malaria vaccines, and 2 countries are implementing a hybrid schedule. So a combination of both age-based and seasonality-based schedules. So this research aim number 2, looking at seasonality, is precisely intended to generate evidence, real-world evidence, and knowledge to optimize the approach in areas of highly seasonal transmission. And now I would like to give you a brief overview of the research projects that have been awarded by Gavi Alliance to undertake research around these 2 aims. So for aim number 1, around uptake, we are conducting research in 4 countries, namely Burkina Faso and Mozambique, which are the protagonists of this webinar today, with a research consortium led by PATH and other stakeholders at global, regional, and national level, and local level as well. While for, again, research aim number 1, still on uptake and synergies, the second consortium is conducting research in Kenya and Liberia, led by Saben and partners. And the aim number 2 projects are, on one hand, in Guinea and Benin, led by the European Vaccine Initiative and partners, and in Nigeria with the Malaria Consortium. So with this overview, I'm happy to pass the floor to Saira again for the next slot. Thank you.
Thanks so much, Eleonora. Okay, so for today's presentation, we'll be focusing on Gavi's learning agenda activities, as Eleonora said, in 2 countries, in Burkina Faso and Mozambique. At the time of this work, Burkina had introduced the vaccine in 27 districts, and Mozambique had started its phased introduction in 1 province of Zambezia. As mentioned before, PATH had worked closely with colleagues at CRSN and at Maraxis to assess the value of integrated interventions in improving the uptake of the malaria vaccine. Next slide. Just for a bit of context, we've compared the malaria vaccine schedule between the two countries. In Burkina, the dose schedule is 5, 6, 7, and 15 months for the 4 doses, whereas it's 6, 7, 9, and 18 months in Mozambique. To get a little bit more into the key findings, we'll turn it over to the speakers now, starting with Dr. Ali C., and he'll talk more about the key findings in Burkina Faso. Over to you, Dr. Ali.
Thank you very much, Sarah. I'm very happy and delighted to be able to show the health system and caregiver feedback on integrated approaches that we conducted with the malaria vaccine. So first of all, slide please. First of all, I would like to show the different partners that are working on this project. In Burkina Faso, it's a National Institute of Public Health that was the key implementer partner, with a technical partner that is PAF, that was very supportive since the conception of the study, the implementation, and currently for the dissemination that we are now doing. And the context of this study is that malaria, we all know, is a high burden, and principally in sub-Saharan Africa, where 95% of all malaria cases and 96% of all deaths due to malaria occur in this.
Wondering if we lost connection for Dr. Ali. Perhaps we can.
So Burkina Faso is a
Dr. Ali.
country with 10 million cases in 2024 and 3,000 deaths that occur in this year. And the malaria vaccine are being seen as a very prominent intervention that could help really to downsize the burden of malaria in Burkina Faso. And therefore, it has been introduced in 27 districts in February 2024. And below you can see the map of the Burkina. All the yellow part in the northern part of the country is where there is no malaria vaccine introduced in 2024. And the green part that is mostly in the south and the east, this is where the malaria vaccine was introduced, this 27 districts. Slide, please. What did we do as intervention during this study? Slide. So we performed 3 main interventions that was introduced for the uptake, to improve the uptake of the malaria vaccine. And the first one is the default tracking, meaning that we search and we vaccinated children who are not up to date with the vaccination during routine vaccination. And the second intervention was the missed opportunities for vaccination. In that one, we searched and we vaccinated children who were not up to date with the vaccination during any contact with the health facility. And the third one is the SMC Plus, where during the SMC campaign, we shared and we vaccinated children who are not vaccinated with vaccination during seasonal malaria chemoprophylaxis. Slide, please. So for the first intervention, the default tracking one, we shared and we vaccinated children who are not vaccinated during routine vaccination. And for that one, the health workers, they review the vaccination register to identify the defaulters. And secondly, these individual details are recorded in a defaulter register, which was shared with the community health workers. And the third time, the community health workers, they actively search for defaulters and they refer these children for vaccination with the health facility, which need really a good communication with the health team. And for the second intervention, which is the missed opportunities for vaccination, we identify and vaccinate children who are not up to date for their vaccination during any contact with the health facility. By any contact, we mean that during any contact the mother or the child has with the health facility, that could be during the family planning, the prenatal or postnatal consultation, the well infant consultation, curative consultation. All these opportunities was really taken into account really to find these children. And for that, at any time we have this contact, systematic verification of children vaccination record is done, and the individual details are recorded in a defaulter register. And after that, ever we are able to immediately vaccinate the children, ever we have to give an appointment to these children to come for later vaccination. And for the third vaccine intervention, which is linked to the SMC, during the SMC campaign, we identify and we vaccinate children who are not up to date. And for that, we check the vaccination record of all children during the SMC Plus. That is done door-to-door visit, and we identify the eligible children, and the child list is submitted to the facility API manager at the end of each day. And by the time we finish the SMC campaign, the 5 following day was used really to catch up these children for vaccination. Slide. What did we learn after these 3 interventions that we conducted in this 4 district? Slide. So first thing is the uptake of be aware that when I'm talking about the uptake of a vaccination, even though our focus is malaria vaccine, here it's all the vaccination are concerned, and 607 children were identified as not vaccinated, not up to date across all intervention. Across all the 3 intervention, it was a total of 607 from the study period that was 4 months from July and October 2025. And for these children, as you can see in the right side on the figures, children identified varied by district. We have the default tracking that accounted for nearly half in Daan. Daan is in the graph, the blue dark one, while the SMC Plus accounted for nearly half in Manga, which is in the red. And out of this 607 children identified, 494 were caught up. Means that our rate of to caught up is 81% for all vaccines together. But if we consider only the malaria under 65. So for the malaria vaccine, it's roughly 84%, while in total it was 81%. So this is one point that we have seen. Slide, please. The second point that we learn is the high of the intervention. So according to the community focus themselves, on a scale of 1 to 5, they deem the intervention acceptable or And to support their opinion, they mentioned that first, the intervention is feasible and equal. They found that we integrated in existing workflow, in some cases reinforced practices that just should have been doing, but not done. But the intervention was a kind of vehicle that really support them to go to these activities. And the intervention provide an opportunity to identify children who are not up to date. And they found that the door-to-door approach facilitate access to families and child health record to check for the vaccination status. These are some aspects that support really their opinion to give, they gave. Slide, please. So now for the facilitating factors for the implementation of the study, we have grouped them on 4 main headings. The first one is the stakeholder engagement. The stakeholder engagement commitment of all stakeholders involved from the outset of this was really key for the success of the intervention that we implemented. And point number 2, which is very important, is also the personal engagement, the personal initiative of the health workers and the community health workers. We found that some health workers and community health workers were very enthusiastic and innovative. That was very helpful for the implementation. The third point is the trust that people are really placing on the community health workers. They have a good auditory in the community, which was very good point also for the success. And we provide close supervision and communication between the research team and the health facilities. That was really helpful to really fill some gaps that occurred during the implementation. And for the stakeholder engagement, training was really important because we had sessions where we pulled health workers from different intervention sites to work together, and the experience sharing was very important. Establishment of tools. We established 2 tools for this study. The first one is the use of children identification lists. And the second one is registers for identifying children not up to date. These 2 tools were very central for the health workers to guide them really to work with the community health workers. Awareness, given the malaria burden, the awareness of malaria burden promoted really the caregivers to accept the vaccination, and also the regular monthly meetings that community health workers are holding with the community for sensitization, putting in the center of this meeting the discussion on loss to follow up also helped to raise the awareness on malaria vaccine. And also for the parents, raising parent awareness of the need to keep the children health record at home, or to entrust it to somebody where when the health worker, community health workers are around, they could really find information was also important. And finally, the resources. The availability of resources was really a facilitating factors to cover the fuel and communication costs for catch-up visit, and also the availability of vaccine, because you can find unvaccinated children. If you don't have really vaccine available, you will not make it. There was also some challenges, and the challenges are twofold. The first one is the facility readiness. The high workload of the health Sorry about cutting. So the high workload of the health workers at each health facilities and insufficient number of the staff. So one of the district health management team was saying one of the difficulties and constraints in the field is staff shortage. So it's really something that was highlighted in several health facilities. The involvement of community health workers in numerous activities is also an issue because they are doing a lot of sensitization and mainly during the SMC Plus campaign, they are very occupied with that, and we were involving them also with the implementation of our intervention. The logistical resources were also insufficient, mainly the motorbike and fuel. And the last one is the lack of capacity and technical challenges in updating the electronic immunization record. So for this one, at the beginning, our idea was to rely on this EIR to really find the defaulter, to track the defaulter and try to vaccinate them. But we help the health facility to update the registered, but at the end, we were not able to use it because of technical challenges. The second group of challenge is how to reach out to children. So most of the SMC occur mainly in raining season. That is the season where we have a peak transmission of malaria as well. And the parents are occupied with farming, so there are absence from home. And it's difficult to locate really certain children because of the mobility of mothers, caregivers, parents going to farming and other activities. And there are also areas that are really difficult to access. Accessibility was also one of the challenge for this intervention, and loss and damage of children health record. So when there is no record, it will be very difficult to get accurate information. What we have seen also, there are some effect on the performance of health workers. So we realized some improvement in daily practices of health workers and community health workers, maybe because we were there talking to them and trying to recall them that they have to do this and this, even though they are supposed to do it. But with our presence, they have really to take care of these activities. And one of the health workers said, to highlight this one, all staff have been trained on how to identify those who have been lost to follow up, how to identify missed opportunity, and how to catch up in practical terms. So at all levels, whoever is on duty can catch up on missed opportunities. So the training we provided was really an asset for them for improving their performance, not only for the malaria vaccine, but for other activities that they are implementing. So it's increased the reflex for them to systematically check vaccination status at all points of vaccination, and that reduce the number of children who are not up to date for the vaccination. Slide, please. So for the cost of the intervention, we try to do the costing of the intervention, and we realized within the three interventions that we implemented, the lower cost per child vaccination is the missed opportunity for vaccination. So the two other, the defaulter tracking and the SMC Plus integration are more or less similar, but identifying the missed opportunity for vaccination seems to be the less cost and to be advisable for setting early for interventions that will be taken up. So to conclude, I may say for the two intervention, missed opportunity of vaccination and SMC Plus, we find that integrating record checking into routine services and mass campaign is acceptable and feasible without placing an excessive burden on health workers. And this intervention can significantly increase the number of children caught up. And for the defaulted tracking, we found that the effectiveness of active search by community health workers and mobile teams for children who are not up to date depend on two factors mainly. One is the accessibility, is to access to locality, and the second one is to find the parent during the raining season. Slide, please. So the lesson on equity that we also learn is first actively seeking out opportunities to contact make it possible to reach children who previously escaped the routine system in place. Secondly, we found that integrating services improve access to for the most vulnerable population. We found the role of community health workers in including
Okay, I think we might have lost Dr. Ali just on this last slide. So maybe we can move to the next slides on implications for sustainability and scale up in Burkina. And some of these slides were informed by conversations with the NMCP, so the National Malaria Control Program, and with the EPI to think through how these interventions could be continued and scaled, and some of the needs around those scale ups. So there's material resources, human resources, increasing staff numbers was a major limitation that we found, but that could be addressed by building in capacity building through this work, financial resources around motivation, and certain governance structures to allow for ongoing training and supervision, which was a big piece of the work that we were also supporting as well to ensure good implementation, clarification of the roles of each actor in the system, and reduction in the number of doses per vial. And recommendations from this work for other countries that are introducing the malaria vaccine. I think the Burkina Faso story, and I'm hoping Dr. Ali will be able to join us back for the Q&A. There was a really strong collaboration that was established from the outset of this project to ensure good collaboration between the EPI and NMCP, and a lot of work that had gone into code design, joint planning, and supportive supervision. So from design phase to implementation to follow-up, monitoring, and ensuring that all the lessons learned through implementation were fed back to support adaptation, but also to think through sustainability. And this last point, I think, is an important one in that this doesn't stand out alone just for the malaria vaccine, but it's actually integrated into interventions that already exist in the delivery system. And again, by doing that early capacity building and that on-site training, we can build those workflows into sustainability. Thank you. We're hoping, again, that Dr. Ali will be able to join us more in the Q&A if there are specific questions there. Otherwise, I'll pass it over to you, Daan, to walk us through what happened in Mozambique.
Okay, thank you, Saira, and thanks for the opportunity to share our insights from the work in Mozambique on the integrated approach to malaria vaccine. Next slide, please. The Mozambican context, we do have also more than 10 million cases annually and 10,000 deaths. And we have a lot of people that repeatedly will get it. The province in Zambezia where we have introduced the Malaria vaccine has at least more than 50% prevalence among children among young under 5. So it's quite severe. And if you look at the coverage, although it's almost 90% penta coverage and 80% in Zambezia, the malaria vaccine was introduced in August 2024. And what we see is a low coverage of the third and fourth dose. And if you look at the graph, you actually see that the dropout rates are quite substantial for the dose 1 to 4 and 1 to 3. So the challenge is how can we leverage the introduction of malaria vaccine to strengthen routine immunization, because the other vaccines are quite have a high vaccine rate. Next slide, please. So what did we do? We actually had, alongside those objectives that were presented by Gavi, two parts, and it was the integration of immunization on early childhood development and the defaulted tracking. So we wanted to utilize the malaria vaccine visits and also to improve the uptake of malaria vaccine. We implemented in 2 districts in Maranhão da Costa and Pebana in Zambezia province, which is up north and you see it on the right in the chart. And we also did especially understanding of the acceptability, feasibility, and costs during the early implementation phase. Next slide, please. So the intervention one was on early child development. It consisted of 3 components. One was the playbox sessions at the health facility in the waiting room, where community health workers were actually playing with the children, using all kinds of toys. There was a group session with the caregivers and the children, and they had all kinds of handmade toys. And this was done 3 times a week. And it was quite refreshing to see how well received these sessions were, and the caregivers really enjoyed it. Then second is we did the monitoring of developmental delays and milestones of children during the health visits. So individual assessments on different kinds of domains like cognitive and social skills and developments. And we had also the use of developmental milestone posters to be used. And third, it was part of the individual counseling during the visit, so to give guidance on responsive care and early learning and referral when it was needed. Next slide is the intervention 2. There was the defaulted tracking, where we had systematic identification by the health facility workers to look at the registry books and to see which cases were actually defaulting, so to make sure that we could follow up and see in which community these children were. And then the community follow-up is actually with the focal points and the community leaders to raise awareness and start mobilizing that, and to make sure that the defaulters could return to the health facility for vaccination. And in order to do that, they made some plans and also used mobile brigades to reach the far remote communities. What did we learn? Next slide, please. We had practices that we expected were not consistently implemented. In the beginning, when we saw that although the growth monitoring is a standard national policy, it wasn't really systematically implemented across the health workers at different facilities. For example, it was also that these sessions, and we had some midterm reflections where they admitted that there was no systematic practice in place to detect those delays. And so that was a lot of a less and limited number of children were detected that they were behind. And even prior to the intervention, the training was with the health workers were less familiar how to screen and how to conduct it systematically. And also on the defaulter tracking, where only 20% of the health facilities had actually a functional defaulter tracking system in place, especially the remote facilities with difficult to reach with far distances to the caregivers had no functional defaulter tracking system in place, whereas there the biggest gains could be reached in terms of equity. If you look at the ECD integration, the caregivers the integration of ECD and malaria vaccination provided a strengthened package, which was highly valued by the caregivers, and they thought it was a very essential part of the services. And integrating these services has an advantage of taking of the touch points with the health facility systems for immunization. So they used that also to conduct developmental screening and diagnosis to provide also more opportunities for immunization uptake. And also to make sure that the caregiver were aware of preventing future developmental delays. As a quote, it's nice to say that I didn't decide to come for the vaccine. I wanted to weigh my baby, but when I found there was vaccine, that's when I decided to let my baby vaccinated. So taking care of every opportunity to also increase the number of vaccinations for malaria. The other is that we saw that there is an unaddressed gap in parenting skills. So it is good to reinforce what you have to actually should do as a good parenting and to promote playing with the children and talking to them as early as possible. These playbook sessions resulted in a calmer waiting room and more engaged caregivers, and also including some fathers. So at least the first sign were positive that they say people and their children were more comfortable going to the hospital. Next slide, please. Here's an example of the play. Oh, can you just show the image of the playbook session, please? Yes. So this is an example of what such a playbook session entails. You have a mat and where children are actually played by a care worker and all kind of tools and people sitting around and see how it goes. And we reach about 4,000 caregivers on a monthly basis with this kind of approach. And of course, everything was done in local languages. Next slide, please. The ECD integration, if you look at the health workers, there was a high acceptability through training and mentorship. Health workers were strengthened with their skills to conduct growth monitoring and also check on the progress of the children. And they are now more comfortable to make an actually assessment if the child is far behind or not. The studies that the intervention that were designed using a human-centered design principle that contributed to a high acceptability and easy integration into the existing workflow. However, it is extra work that the caregivers of the healthcare workers have to do. And that, of course, is not sustainable if there is no adequate staffing or ongoing support for that, because they still have to do a lot of other work. So addressing these issues like low-cost materials, change management, and also like space optimization and even literacy, adapted materials will help to mitigate some of these barriers that are. And if you look at the impact that we have, and when we look at the detection increase in developmental delays, and the graph on the right, you see the pre-intervention between the intervention areas, and also we had control. They were like at the intervention was increased significantly during the intervention period of 4 months, and at the bottom part gives the average number of children with developmental delay detected. Before it was almost 1, and after it was more than 18, so more than 20-fold times increase, whereas the comparison facilities in the different districts remained the same. So we can say there was substantial increase, and there was also, however, sufficient insufficient time during a short period of implementation to actually assess the vaccination rates uptake significantly and to see if there's were real changes. So the question is, for us, for future learning, are the caregivers more likely to return for subsequent vaccination because they have a positive experience, but that will need to be investigated in the future with some more longer time available. If you look at the defaulter tracking, we saw that there was an active community structure engagement. We really included the health workers locally, focal points, committee members, leaders, to make sure that there was a mobilization to increase the follow-up of the children to detect who were missing. And there was technical support via Village Reach. They provided technical assistance and all the materials, and also from the district departments, from the Ministry of Health, the supervisors were actively computing, and also the Ministry of Health and the malaria partners contributed to be able to monitor the tracking. Next slide, please. High acceptability among caregivers, among health workers and community members doesn't mean that it's successful implementation. Of course, there is stakeholders, they value the community structures, the systematic approach of tracking it, and user defaulted data to plan mobile brigades. And we did see an increase on defaulters that came. And also, like, on the other hand, we still have barriers. And those barriers, one of them is the manual record keeping burden, causing a lot of extra labor to keep track of all these extra things and planning, etc. And that also is to the point that there is lack of digital platforms. There are no digital systems, so even the labor is increased, and also chances of mistakes are there. In addition to what also was mentioned by Dr. Ali, we have also transportation challenges, especially bicycles and bikes, and also fuel for the mobile brigades. And some of the facilities have really large catchment areas, and they are very remote, so there's long distances for people to travel. And also there we see inadequate staffing levels. So these are 4 interconnected barriers. Next slide, please. That are more fundamental than like incidental, and they need to be solved through programmatic adjustment in combination with proper planning. So we see that on the manual health system, it's unsustainable to keep track of all this extra defaulters and planning with different forms and etc. So digitization is really needed here. And then in the field itself, there is some ambiguity between the roles of NMCP and EPI. Some people say, why do we need additional colleagues only for malaria, chasing the people? So there is some misunderstanding and better communication needed there. The transport I've already mentioned, with some challenges there with fuel, etc. But also like motivation for the community health workers. We need to make sure they are somehow incentivized, either by t-shirts, material, or transportation. And then the last slide, next slide, please. What are the implementation and recommendations for other countries? So it's good to understand that high acceptability was there among health workers and caregivers, and that is the basis for a successful future and integrating the services. However, acceptability and the proof of concept success are needed. It's not sufficient to address those systems constraints in a sustainable manner. We need to have additional solutions, and I mentioned in the previous slide a few of them. However, the ECD integration intervention was really promising. We saw increase and improvement on many aspects, and one of them that stood out for us was the developmental delay that has been detected, so that the children could be referred to for additional assistance. And there was strong engagement of local stakeholders from both the technical partners through district level and health community workers, so to make it a success and joining together. However, it is good to understand that we have limited time due also factors. We only had 2 or 3 months actual implementation of the interventions. So acceptability and feasibility, and also the cost that we did, was positive. However, the Ministry of Health colleagues said, yeah, in order to follow or advise or change policy, we need at least a minimum of 6 months with sustainable of clear data to be analyzed before we can actually decide if we want to scale this up in terms of policy and other things. So I think given the time, I would like to leave it at this and give you the floor back to Saira.
Thanks so much, Dan. And thanks, Dr. Ali, and thank you, Eleonora, as the panelist for this conversation. Really interesting to see the results on the missed opportunity vaccination, as well as the SMC, and what that looks like in terms of integrated approaches, as well as defaulter tracking, which was the intervention in both Mozambique and in Burkina Faso, as well as the early childhood development integrated work as well. So thank you very much for sharing some of the high-level lessons learned and recommendations and implications. I'm going to walk us through a few of the questions that have come through on the Q&A, and people should feel free to add more if you have others. But I'm going to try to direct these to some of the panelists, as well as some other PATH colleagues who are on the call who have been supporting the malaria vaccine technical assistance work as well. So this first one is from a WHO colleague in DRC, but I'll give a little bit of context, and I think, Eleonora, this question might be best directed towards you from the Gavi perspective, or just understanding the other potential learning platforms for the malaria vaccine work. But in the DRC, we've introduced the malaria vaccination in 2024. To date, vaccination coverage for the 4th dose administered at 15 months remains low, despite several strategies that are being implemented. If possible, please share with us any platforms or exchanging experiences that we can share strategies and experience with experts from other countries, with the aim of improving coverage of the 4th dose of the vaccine. I think this platform, this particular webinar platform, provides that opportunity for some sharing. But I wonder, Eleonora, I can pass it to you to see if there's anything else that you wanted to share from Gavi's perspective. Over.
Thank you very much, Saira. So the question is about further knowledge translation and dissemination activities. Yes, there will be a number of those. And in fact, today's webinar is the first of a series of several activities we will be engaging in a collective manner. So there will be written and online opportunities. So there will be reports, briefs, there will be media coverage, stakeholder meetings, community dialogues. Basically, there will be a series of diverse engagements at country level and also at global level, mostly driven by the implementing consortia, but we will also engage in cross projects activities. Namely, there will be a consolidated report which will stem out from a joint workshop we will be conducting soon, and there will also be a journal supplement. And further to this, there will be more targeted, actually, dissemination activities. For example, upload of all projects materials onto repositories, such as TechNet, for example. But also we will follow up. Most importantly, I believe it's important to highlight that the evidence that we are generating is really going to provide the core information to guide optimization of malaria vaccine program, but also other vaccine programs within the second year of life platform and other primary healthcare platforms. So we will engage in targeted activities at country level, first of all, starting with the research implementing countries and also the other malaria vaccine implementing countries. So we will be looking for opportunities to actually operationalize this evidence and this knowledge. So the entire purpose of the learning agenda is to make this knowledge available to all stakeholders and to make it actionable for hopefully rapid integration and utilization within not only EPI programs, EPI systems, but also health systems in general, because I think what we are observing from these two projects is that, first of all, the malaria vaccines can be a driver to strengthen other interventions, uptake and coverage. So we definitely need to leverage those vaccines, the malaria vaccines. But also there is no kind of vertical challenge specific to the malaria vaccine per se. So the challenges we are observing really relate to health systems and service delivery at large. So that's really what we need to focus on for knowledge translation, which will be really the focus of our support over the next period.
Thanks so much, Eleonora. I'm going to direct this one question to my colleague, Yvette, who is on, I believe is on the call with us too. It's speaking specifically to the Burkina Faso context, but the question more aligns with demand generation and community engagement. So the question here is, have you considered using religious leaders, churches, or other religious centers who could also improve the mobilization of those who have been lost to follow up for the subsequent malaria vaccine doses? I wonder, Yvette, if you would be able to speak to that a little.
Yeah, thank you, Sarah, and hello, everyone. Yes, I think generally speaking, faith leaders and other community actors are so essential to any overall strategy to bring caregivers, children into vaccinating centers. So there needs to be a lot of communication through health workers, but also through community actors, through community health workers as well. And these leaders are essential to the ongoing process as they themselves increase their own knowledge and ownership of the information related to dosing schedules and overall immunization. So to the extent that we can get community leaders, community members owning that information, I think that is really essential to the success of any strategy. Over.
Thanks, Yvette. Dan, there's a question about whether engaging in ECDs in fact led to increased opportunities for vaccination. I think in your slides clearly talked about, greater detection by integrating ECD with the malaria vaccine. But then I think the question is on the reverse, did that in turn lead to increase in access of the malaria vaccine?
Yes, so as I said, one of the lines on the slide was actually a quotation from a caregiver saying, hey, I came for just my child to be waited for, and then I heard about this vaccination, and then I decided to vaccinate. So clearly there is evidence that it attracts also a new opportunity for vaccination, as long as the nurse and the caregiver or health worker are actively informing them. And through these sessions, like the playboy session, people are engaging in a group, in a waiting area. And if you talk about also the malaria vaccination and the program about that, then at least it's in a natural environment linked to ECD, and then it's actually contributing to increase.
Thanks so much, Dan. Dr. Ali, there's a question about wanting to learn a little bit more about the EIR tool in Burkina Faso. I'm wondering if we'll check your connection also, but are you able to speak to that a little bit more about the scale up of the EIR tool, what you found in the field about use, and then where you see the use
Yeah.
of the EIR tool moving forward. Yeah, over to you.
Thank you very much for this question. I think the EIL tool was put in place by the health system in Burkina Faso and in different health districts to really help to have a register, electronic register of immunization. That would have really easier the default tracking and easier the non-vaccinated to find out vaccinated children. But unfortunately, what we notice is that the register is not up to date. It was very far behind completion, and it was not up to a level that we would be able to use it during our intervention. So what we started to do is to help the different health facilities that was engaged in our study to fill the register, the electronic register, and this was done with the support of the study team. We have a workshop with health workers, with API team, and also with this data health information system people that help us really to do that. But at the end, we had completed a version of EIR, but it was not able to use because the health staff was lack of capacity to use it, but also because there was a lot of hiccups coming, technical issues that pop up when they try really to use it. So it means that the things is not well settled, and there is a need really to continue working on. It's a good tool, but need really to be functional, which is not the case now. Over.
Thanks, Dr. Ali. Okay, we also have a question about use of child health records and challenges with either loss, damage, incomplete, or inaccurate child health records. And I think this was something that we experienced in both countries. Number one, about accessing it, and then about interpretation and the validity of that data. So I wondered if we could hear from actually both of the researchers, Dan and Dr. Ali, about challenges with accessing that data, particularly for the malaria vaccine, because it was relatively new compared to others, kind of the status of the child health records in some of the more in-depth work that we were doing. And I think some of the challenges overlap between the countries and some of them are a little bit different. So maybe, Dan, I can pass it to you first to talk a little bit about accessing the records and use, and then we can also ask the same question of Dr. Ali. Over to you.
Okay, so our experience is that the health facilities keep also records. So they, in addition to the child health record that they give to the caregiver, they also keep track of the malaria vaccinations in their own books. So in that sense, there is already some backup in case there is a problem if the caregiver is lost or didn't have the record with them. We didn't see that it was a major issue in general terms because sometimes also the caregivers remember which month they went for vaccination. So, but that has to be double checked because the problem but more is actually that caregivers, given the distance, they might, because they're also seasonality and given the work they have, they travel between different areas. So they are not always going to the same facility for follow-up vaccinations. And that causes a problem because then the health facilities, the new ones, they don't have records of any vaccination of these children. And then you need to have your child registration card with you. If you don't have it or it's damaged, then it becomes a problem because the nurses will not vaccinate the child unless there is proof that she has gotten the previous dose.
Thanks, Dan. And can you say anything more about recognizing from the the records when additional vaccine doses are due or should be given? That was also well labeled or well assessed in the child health records.
Yes, in principle, all the vaccinations should be marked that the child got on the child record. So in that sense, if you don't have it, then it falls back to the registered books of the health facilities. But in principle, the registration, the nurses do a good job by filling in both the health records as well as the child register cards. So if they have them with them, the parents. So we don't see like additional problems with misinterpretation of that, because the nurses are well instructed that it has to be registered. And this is across any kind of this. So it's not specifically for malaria, it's just in general of any vaccination or any growth monitoring registration.
Great. Thanks, Dan. Dr. Ali, a similar question for you. During the implementation, what challenges did you see or not with accessing the child health records as well as documentation of the malaria vaccine? Over to you.
Yeah, of course, we really face this issue of accessing to the child health book because people are moving around. And specifically in a district of Manga, there was a lot of movement around. We found people that are out of their locality because they come from outside the district being there and not sure that you will find the health booklet with them. And also during the raining season, when the parents they used to stay on the field, and we have access to them. They will stay with their children there. We can have access to them, but they have fear about the loss and damage of health booklet because of the rains. They don't want to carry it to the field so that you will find them, but you don't have access to the data because the data, the booklet remain at home while the children and the parents are in the field. You can find the children, but you don't have any information really to know whether the children is up to date as far as vaccination is concerned or not. This is one thing. And the other thing is that when the mothers they went out from home, sometimes there is a caregiver that is taking care of the child, but this one doesn't have access to the health booklet. So you can find the caregiver with the children, but you don't have access to it. So this was where I was saying some health workers, they have this innovative idea asking to mothers, they can have a picture of the booklet in their phone for the place like Manga where several people, they have a smartphone. The mothers can have it and hand, because they are always moving with their cell phone, they can have it with them. And when the health workers get to them, they can access to this information based on these pictures that they have in their phone. This was creative. We find it really creative. It was really own initiative by the health workers, but it's not something that is generalized. And we really noticed that as a best practice, one of the best practices that we made during the study.
Thanks, Dr. Ali. Okay, maybe one last question to each of the country researchers as well. And I think this will be a good note to end on. It's a question from Posi. Most interventions for reducing dropout rates usually show positive impact, but the problem is always on sustaining those practices outside of the project mode. How do we address the persistent challenge of ensuring that this is done in project phase, but then is also sustained after project closeout? Dr. Ali, maybe I can ask you this question first. I went through some of your sustainability slides towards the end, but I don't know if you want to share just in one or two sentences what opportunities the project presents for building some sustainability of these practices. So over to you, and then we'll pass it to Dan as well.
Yeah, yes. So I think most of the interventions that we did was a kind of reinforcing what was supposed to be in place by the health workers, but not done really. So it was a kind of our intervention came to remind them that they have really to comply with what was planned for them to do as a strategy to really improve the uptake of the vaccine. And they really recognize this way where we say that the performance has really improved. They realize that yes, with maybe with our presence, the trainings that we provided, the different workshops and meetings that we had, remind them that at any time they really do the job, they will have a good result. So I think currently with the sustainability points that I highlighted, there is really a need to have a continued training and supportive supervision. And the National Malaria Control Program and the API management team need really to work together hand in hand, because sometimes it's not clear whose responsibility is to do what. And we saw that what we did really improved not only the malaria vaccine uptake, but all the other antigen uptake as well, meaning that it's not only an issue that is related to malaria vaccine, but the entire system. It's a system issue. And this needs really to be addressed. Somebody needs really to record people on what they have to do and to be accountable for what is planned for their duty. Yeah. And I'm pretty sure that it will pick up. Over.
Thanks, Dr. Ali. Yeah, over to you, Dan.
Okay, so as said, we had a short time of implementation, but we have actually quite some positive feedback from the district authorities and also the provincial authorities and the national authorities that this is something that they want to continue. Everybody was willing to invest from their side to see if they can continue with the trainings and also have trainers of trainers that to spread the word. One thing is that the NMCP has introduced specific monitoring forms that now they're going to be used on a regular basis to make sure that they detect at an early stage potential issues with the health facilities. So we only introduced this in 2 districts at 10 health facilities, but the next step is that the DDS and the DPS, the regional responsible from the ministry, are actually trying to see if they could enlarge it to other health facilities in those districts, and then also to continue with the work that is being done. And that is also followed up by PATH and other projects that they have in the region. So, and also like stakeholders like Village Reach, they are also actively engaged in this. I know that Village Reach is busy with a tool to digitize certain things. So the national ministry also has indicated that they like these kind of digitization processes also to include the malaria vaccination. So if you have this kind of information available across the health facilities, you can also stimulate the tracking of maybe people that move around easily without any mistakes. But as said in my slides, the ministry says, okay, we want evidence that this works. And so we actually need more data before they actually are willing to invest a lot of time. So sustainability also comes with clear evidence that things are working at a higher scale, at a longer period that we currently have. So it is what it is at the moment, positive engagement, but especially on the health workers' motivation, you need to make sure that it's not a manual burden with filling in a lot of forms and doing a lot of things. So there needs to be some smart solution to help those people with this, either dedicated staff or maybe some inventive digital tools that can support this.
Thanks so much, Dan. Okay, we'll end on that note. I wanted to thank everyone. We're coming up to the end of our time together. Thanking all the panelists for your participation for this first webinar, and also for all of the participants for joining today. We're looking forward to hosting another session, as I had mentioned at the top of the call, in April to coincide with World Malaria Day. And as kind of a closeout for this call, we'll make sure to share the recordings with all of the participants as well as the slides. Thanks again, everyone.